In examining the wrist, it's important to mark our anatomy as we do elsewhere. First of all, the radial styloid, which we can grasp between our thumb and finger in this area, and then we can mark like so. The edge of the radius we can often feel by moving our tissue back and forth and up and down, and the edge of the radius is right here, coming onto the styloid, coming across and locating the joint between the radius and ulna, which is right here. So the radius coming across like this, the joint there, and over onto the ulnar styloid, which is right here, with the ulna sitting here. Looking at the skeletal model with this, the radial styloid here, coming across, and the joint between the radius and ulna, and then the ulnar styloid here. We now know that the area beyond that, the proximal row of carpals, the scaphoid, the lunate, the triquetrum, and the pisiform, which forms the bump underneath the hand, are really the mobile row. The distal row, the trapezium, the trapezoid, the capitate, and the hamate are not very mobile, and so they're much less likely to have discomfort in them. This area is an area that's frequently traumatized by people falling on their outstretched hand in the flexed position. Injuries in cars where people are holding onto the steering wheel are another common cause of pain and problems in this area. We carefully palpate the styloid of the radius and then the ligament that connects the radius and the carpal bones just beyond that. This can be confused with tendon pain and the de Quervain's tendinitis, and may be involved actually in de Quervain's as well. So it's important to differentiate by actually palpating the tendon versus the styloid and the ligament beyond it. We can then walk across and feel the ligaments attachments at the radius and the carpals, coming down onto the scaphoid and the lunate, and checking for motion of the lunate by pressing upward or laterally and with a downward motion to see if that lunate pops up under our finger. But people will have tenderness in these areas if the ligaments are damaged. So very careful palpation in small movements right around those carpal bones is extremely important here. And marking the areas where they're tender so that you can come in and inject just those spots. These will often be where there are tiny prominences on the bones that you can feel, and the patient will say, "That's my pain right there." And there's a tiny little bump there where the ligament attaches. We then come across to the joint between the ulna and the radius, and the ligament that attaches right in here, and oftentimes that particular ligament is tender. And then across to the ulnar styloid, and then the TFCC that's just beyond that with the cartilage in the joint right there, a little space in that area, and then again carefully palpating the ligaments over the carpals in this area. The ulnar carpal ligament is frequently one that's tender, and we should be able to feel that right on the distal end of the ulna, and then feel the ligament itself right here attaching down to the carpals here. As we come across, we can feel the ulnar styloid and the ulnar carpal ligament, which we can feel between our fingers, carefully palpating the tip of the ulnar styloid, the triangular fibrocartilaginous complex. Just beyond that, a space where we can move the wrist back and forth with our thumb or finger right in that area will frequently be tender. Some people inject into that, other people just inject the ligaments around it, and I think either approach is probably reasonable to do in this area. We next want to come down to the ligaments around the carpal metacarpal junction. This is a frequent area of pain, and people then with this pain, have difficulty opening jars, difficulty doing pincher motions with their thumb because this hurts a lot. We need to begin in the palm and palpate in the palmar surface, coming around the base of the metacarpal and the carpal joint right here, following all the way around. It's kind of a ring around this area, and so we can draw a line that approximates that, coming around like that. We then can move to the metacarpal phalangeal joint, again coming around that joint, realizing that the capsule attaches across the joint, and we're feeling the edges of that as we come around it all the way around the thumb. Injections in this area need to be carried out meticulously, and again with our finger on the anatomy, such as the radial styloid, coming in directly to the styloid and reorienting our needle several times, being careful as we come on the underside to avoid the radial artery and nerve. We may wish to push them aside and to be sure that we're not hitting the artery or nerve in that area. We then can redirect our needle down onto the carpals and inject the carpal attachments of that radial carpal ligament. Our injections come across the wrist, tender points on the carpals, tender points on the distal radius, into the radial ulnar ligament, out onto the ulnar styloid and the attachments of the ulnar carpal ligament, into or around the triangular fibrocartilaginous area, and then all around the base of the thumb at the carpal metacarpal junction, clear around areas of tenderness in the pad area here as well. We then can move out to the metacarpal phalangeal junction and inject around this area. Small amounts of solution, since this is not a large space in this area. If we look at this on the skeletal model, we see our injections carried out on the distal radius, the styloid, the scaphoid, the lunate, and the lunate capitate ligaments, the radial ulnar junction, the distal ulna, and down onto the ligaments that attach to the carpal bones. We inject the distal ulna and the ulnar carpal ligament, and then into or around the TFCC, triangular fibrocartilaginous complex, which has a meniscus in it right here, and you can slide into that or inject around it. The trapezium metacarpal area, trapezium here, coming around the base of the thumb in that kind of fleshy area and injecting all the way around that junction. And finally, the metacarpal phalangeal junction, injecting around that area. The fingers can also be injected. These are very useful in people with arthritis, even rheumatoid arthritis, where the fingers are quite frozen. Injections can relieve pain. The finger joints could be accessed in several ways. Basically, when we palpate these, we palpate around the edges of the joints on both sides of the joint. We can feel the joint line right in the center of our palpatory area, right here. And we know that there's going to be a joint line right here, as well as on the sides here. So we palpate again for tender areas on the sides of these joints. In the same way on the interphalangeal joints, tender areas along the capsule and ligaments on the sides of the joints. When we find these tender areas, our injections are then carried out at the capsular area laterally, like this. Some people actually open the joint up a bit, like this, and enter the joint if they can get into the joint itself. This may be difficult. And some people bend the finger and come into the joint from this direction and enter the joint with a small amount of dextrose solution into the joint itself. Interestingly enough, when one comes in and injects on either side of the joint line in the ligamentous or capsular attachments, one enters this and also feels the solution come out and puff out the other side. In the Hackett-Hemwall text, this very injection is described, and they point out in there that it's not necessary to specifically attempt to enter the joint, because once you're in the capsule, that fluid's going to suffuse through the joint anyway. I find this often an easier approach to inject both sides alongside the joint line on both sides of the finger, and to find that to be a very effective method of accomplishing this whole injection.